Oh, it's a fascinating new molecule because it's a small molecule that was initially developed to target the interaction of XIP, the inhibitor of apoptosis, with caspase-9. The idea was that it would compete with XIP for the binding to caspase-9 and releasing it and inducing apoptosis. It turned out that actually the affinity of LCL161 is much higher for a different type of inhibitor of apoptosis. These are the cellular inhibitor of apoptosis, CIP1 and 2, that actually don't bind directly to caspase, but it turned out they play a crucial role in activating the NF-kappa B pathway. And this is getting really complicated because CIP1 and 2 are positive regulator for the canonical NF-kappa B pathway, but negative regulator for the non-canonical NF-kappa B pathway. And we know that myeloma frequently acquires activating mutation of the non-canonical NF-kappa B pathway. So the target of LCL161 is CIP1 that is actually frequently deleted in myeloma patients. So when I first treated my mice, my transgenic mice with LCL161, what I thought was going to happen was to induce activation of NF-kappa B that would promote myeloma growth. Because if you think about, I'm using a drug that does the same thing that the tumor cells is trying to achieve, that is to get rid of CIP1 and 2. So I was really surprised when I actually saw the opposite effect, that LCL161 was reducing the tumor burden in the mice. And the most incredible thing is that this occurred not by direct killing of the tumor cells. So my initial hypothesis was actually correct. I'm inducing activation of NF-kappa B that doesn't kill the tumor cells. But what happened is NF-kappa B activation occurs also in the host, in the immune system. And basically is giving a boost to these immune cells that now are able to recognize the tumor cells and kill them. So I think is one of the first example of a drug that does absolutely nothing in terms of cytotoxic activity to the tumor, but really boosts the immune system with, in my mind, enormous implication because I think after spending basically 20 years studying genomic of the myeloma tumor, I came to the realization that there's no drug combination that is going to eradicate all the tumor cells. The tumor is smarter than that. There is always the residual clone that can outgrow, but if we come from the other side and we try to boost the immune system is smarter than the tumor, I think, because no matter how the tumor looks, the immune system is able to overcome it. It's just a balance. You want to debulk the tumor enough that the immune system has a chance. And this is now the clinical challenge, is that how we are going to translate the result that we obtain in the mice. And we ran a clinical trial of LCL161 in combination with cyclophosphamide that I think is known to immunology to also boost the immune system. And we had a good result, but not enough. We had some durable response, and most importantly, we achieved durable disease stabilization in high-risk patients. But the challenge is now how to translate it to even a better response rate. And I think the next step is going to be the combination of LCL161 with checkpoint inhibitors that, in fact, we tested this hypothesis in mice, and we found that this specific combination, besides being very well tolerated, cure all the mice treated. So I'm excited about moving to the next phase, that is a clinical trial in myeloma of LCL161 with a specifically PD-1 blocking antibody.